Workshop 3, this one is all about musculoskeletal. So in this session in particular, we're going to do some intros and welcomes. Then we're going to go into what actually musculoskeletal conditions are. We're going to go through these 3 particular ones in detail. So arthritis, and we're going to do osteo and rheumatoid. We're going to do joint replacement, and we're going to do osteoporosis. There is also lower back pain, and that will come in a separate workshop because there's lots to discuss on the lower back pain one in particular. But for tonight, we're going to go through arthritis, joint replacement, and osteoporosis. And then we're also going to look at doing some planning for clients with musculoskeletal conditions, so we can kind of consolidate all the learning we've already done, have a couple of little tasks just to check that we're all on track. So let's get stuck into musculoskeletal conditions. Just as a kind of broad overview, this basically means any conditions that affect muscles or skeletons or bones and joints. So these are the main areas: muscles, skeleton, bones, joints. They're the kind of things we're looking at with musculoskeletal conditions, and just really making sure that we're honing in on all of that content, all about what are these particular musculoskeletal conditions. Now, let's start with the most obvious one. Straight in there, let's start with osteoarthritis. Now, most people get a little bit confused between osteoarthritis and rheumatoid arthritis. So I'm going to do these in a comparative way. So once I've introduced both of them, we're going to compare what's different and what's similar about these two. Now, you are most definitely going to have clients that have osteoarthritis. I can put that one straight out there now. Nearly everyone over 60 years old has affected joints from osteoarthritis. And the reason for that is because age is a massive risk factor for it. It is basically inflammation and degeneration of the joints. So if you basically put your fists together now as if they're kind of 2 bone ends joining, as if it's a joint, when we're moving in normal joint motion, that works fantastically smoothly with synovial fluid being pumped through the synovial joint, and it keeps it all really lubricated, and it allows those 2 bones from not joining. However, over time, maybe massive wear and tear, maybe we do a lot of repetitive strain on one particular joint, or maybe we've got a slight different angle on that. So, for example, if someone's got a misalignment of that joint, there's going to be a slight wonky nature to their joint alignment, which instantly means that there's going to be more wear and tear. So when we're talking about osteoarthritis, we're talking about wear and tear of that joint, degeneration of the joint, which is basically either the synovial fluid isn't being released into the capsule effectively or not being lubricated properly, which means it's not able to lubricate and make that joint easy to flow and easy to move. The other side of that is that if you end up with cartilage on cartilage or bone on bone, you're literally going to get this rubbing motion happen, and as that starts to rub, that degenerates the bones even further, and it causes inflammation where it's really sore, and that inflammation is basically swelling around that area. So it mostly occurs in knees, hips, and also in small joints of the hands, and sometimes in the toes as well. Now, the reason for those areas being the most that we see is because knees and hips have to take a lot throughout our life cycle. We do a lot on them, we weight bear a lot. Not everybody has great alignment of those 2 particular areas, so they're going to wear down even easier. The small joints of the hands and the toes, they come in from either repetitive strain or from pressure. So these are the main areas we're going to start seeing osteoarthritis with our clients. The other difference is that really any joint can be affected, especially if they're using it over and over again, or they've had a previous injury in that joint. So if you think about what you guys do on a regular basis, sport-wise or exercise-wise, if you run a lot, if you swim a lot, whatever it is that you're doing regularly, that's probably going to be the area that you're more likely to have osteoarthritis in as you get older. So, for example, runners are more likely to have osteoarthritis of the knees and the hips in later life, and that's because of that continuous wear and tear of those same joints. Whether that's in great alignment or not, generally it starts to catch up with us. As a result of osteoarthritis, it can get so bad that we actually need hip replacements or knee replacements, and over 140,000 hip and knee replacements were performed in England last year and every year. So it's really important to kind of think about the magnitude of osteoarthritis. Is not just, oh, that it hurts a little bit. It's that it gets to the point that it's so painful that they need to have surgery in order to help that. And we're going to look into hip replacement and knee replacement in a lot more detail and really kind of understand what goes on in those. But for now, that's a big overview of what osteoarthritis is. And the one that people get this mixed up with is rheumatoid arthritis. So rheumatoid arthritis is totally different to osteoarthritis. Let's throw that out now. Let's clear up the fact that arthritis basically means inflammatory. So the itis in arthritis means inflammatory. The osteo on osteoarthritis means bone, so we can associate that with bone. Now we're talking about rheumatoid arthritis. It affects the blood, so it's autoimmune. Now, an autoimmune disease is anything whereby the body starts to attack itself. So this is when, instead of building cells, they start to degenerate from no particular reason necessarily. It's just that autoimmune disease, and we're going to look at what causes this in just a moment. But these appear very differently to what we have in osteoarthritis. So it's not necessarily that the more we use this particular area, that therefore the more it is affected. Instead of it being wear and tear, it's almost by chance of where it will happen. And usually it happens symmetrically. So if someone has rheumatoid arthritis affecting their hands, the chances are they'll see that effect in both hands rather than just in one. Whereas osteoarthritis can affect one more than the other because it's based on our environment and how we move. So there are kind of overall differences between the two. One's autoimmune and one is through wear and tear. Really important to know the difference of these, because we treat these clients so differently from each other because the causes are really different. Now, as part of this, it's stiff, it's painful, it can be very swollen, and it's not just the joints that get affected with rheumatoid arthritis, it's also any other parts of the body. So, for example, my auntie has it affect her eye, in which case she needs to have anti-inflammatories injected into her eye regularly. I had a client that it affected the lining of his lungs. So as it affected the lining of his lungs, he basically was like a COPD client because he really found it tricky to have consistency in his lung capacity. And as a result, we treated him like a COPD client, someone that's really struggling with breathing as a result of chronic obstructive pulmonary disorder. But it can affect any other areas of the body whereby it's starting to degenerate, usually around joints, but not exclusively, and it can be around joint linings as well, and also linings of the organs or other areas of the body. So really big one to think about. This one is a lot less common in England and Wales in general. Only 580,000 people will have it, and it's only about 2 to 3% of our adult population. And that's a massive difference to osteoarthritis, whereby basically everybody over the age of 60 will have. So you can really already start to see these differences, but I really want to hone in on these differences even more so we can kind of really understand what's going on, and when our clients come up to us and they go, I've got arthritis, how do we then know which one it is that they're talking about? So we want to be able to recognize these signs and symptoms, not only so we can say, oh, you meant osteoarthritis, or oh, you meant rheumatoid arthritis, but also so that we have an awareness of when those signs and symptoms get worse, that's when we're able to then refer back to the GP. So we kind of got to really dial into that understanding of what are the signs and symptoms, so we can be aware of, are they getting better or are they getting worse? And that's a good sign of where we need to work in with our medical professionals. So let's look at the signs and symptoms of osteoarthritis first. This is on the left-hand side of your screen. So these are going to be pain, definitely pain, but that can happen in movement and also at rest. Stiffness of that joint, if you think that it comes down to a certain level of synovial fluid needing to lubricate that joint, if they're not really warm, then they're going to find that they have real stiffness in that joint. In particular, in mornings, they can find a lot harder compared to considering working like afternoons, whereby they might have limbered up a little bit by then and got the synovial fluid moving. There's likely to be swelling because the joint is deformed, and as a result of it being deformed, the body needs to protect itself. It draws water to the area to protect it, and that's what we see as swelling or inflammation. Quite often there is muscle weakness around the affected area, and that's because we avoid using it. So if you imagine you've got massive pain, stiffness and swelling in your left knee, when you go to do a squat or sit into your chair or get back up out of your chair, you're going to load the right leg more, which means that the muscles on that left-hand side gradually become weaker and weaker. And you also get a limited range of movement in there. And as we said, you get that joint deformity. Now, if we think about that joint deformity in a little bit more detail, this joint deformity, if you imagine filing away at bone, so this is kind of like when you file away at your nails. So for the ladies in particular listening, if you ever file your nails, then you'll know what I mean. By filing them, they grow back better. They grow, it stimulates more growth. It's exactly the same with our joints. So the problem we have here is that if we're technically filing, whereby we're wearing down and going bone on bone, then as a result, it starts to wear away at the bone. It starts to basically chisel out parts of bone. And that stimulates regrowth, but it doesn't regrow regularly in its normal pattern. It grows these little tiny bumps, these little tiny bony spurs on top, and that can cause a massive amount of locking in the joint. So if you imagine lots of tiny little spikes coming out of that affected area, it can limit movement even more and mean that they actually end up locking, and that means that their range of movement can end up even more limited, not just through pain, but actually physically blocked. Especially if you think about the spine, that's a really common place for it to almost become self-locked. So these are the kind of main signs and symptoms of osteoarthritis. This is what you're expecting to see with someone that's working from wear and tear. Now, this compares massively differently to the rheumatoid arthritis, whereby people will go through massive variations of flare-ups and remissions. So if you've ever worked with someone who has an autoimmune condition, for example, multiple sclerosis, or you know anybody, then you'll notice that they have really good days and really bad days. Now, that's because it being autoimmune, it's prone to have these fluctuations in what causes that, in the pain that comes out and the signs and symptoms. So we need to be really careful, and we need to be really honest with our clients and open to make sure that they understand that we can't just set them the same program for every single day that they come to the gym. Because some days are going to be really good, they're going to feel great, they're going to be able to get lots of range of movement, and other days they're going to be really limited and they're going to have a lot of damage going on and a lot of inflammation. So we really need to be flexible with our clients that have rheumatoid arthritis, and I'd really recommend you give them two programs. One that is for a good day where they're feeling great, that still doesn't overdo it, by the way, and we'll talk about this in just a second, but that doesn't overdo them so that they end up suffering the next day, but that allows them to progress. But also something that allows them to do activity on days whereby they're really flaring up, their condition feels really bad. So they're sort of the main part to consider for rheumatoid. They are going to have a lot of pain, and that's obviously similar to osteo, a lot of inflammation, damage to the joint tissue itself and the joint lining, and then also deformities means that it can look a lot more deformed than with osteoarthritis because it affects the whole area of that where the rheumatoid arthritis is being affected, rather than just in that one joint, for example. And obviously limited range of movement. So your biggest difference between osteo and rheumatoid is because rheumatoid is autoimmune, you're going to have these fluctuations of flare-ups and remissions, and that's what we need to cater for really differently. And then we also know that osteoarthritis is going to be more progressive based on the amount of impact that they have. So when we come down to look at what's actually included in the pathophysiology, what's actually kind of happening, we've explained this to a lot of extent already, but I just want to highlight the three main characteristics on the osteoarthritis side to start off with. They got mild inflammation around the tissues and in and around the joints. There's damage to the cartilage and the bony growths that we said about. So by chunking it down into these 3 little sections, it'll help you remember what's actually going on. So they will help definitely with understanding the 3 key characteristics of osteoarthritis. The other difference is that pathophysiology of osteoarthritis is really age-related and about repetitive strain, whereas pathophysiology is for rheumatoid arthritis is autoimmune, and it totally depends on, it might even depend on what they've eaten the day before, or that they are stressed out at work, and that can cause a flare-up. So it's less linear with autoimmune. We have to really be considerate and dial in with our clients on a day-to-day basis when we're working with them. So let's look at what actually causes these 2 different things. I really want to look at modifiable and non-modifiable risk factors, just like what we were talking about on the cardiovascular module that we did. So for this one, for the modifiable factors, you can see that for osteoarthritis, we're in a place whereby we can actually, to some extent, prevent us from getting osteoarthritis later on in life, much more than with rheumatoid, because there is many more modifiable risk factors that we can choose to do or not to do in our life. So occupation, sports, obesity, repetitive strain, and sedentary lifestyle. Now, obesity comes in massively for osteoarthritis. If you have obese clients, they are very likely to either have osteoarthritis or be developing osteoarthritis around their knees and hips just from the amount of weight that they are carrying. So it's a really important place to dial into, and be mindful of those that are larger are also massively at risk of having osteoarthritis too later on. Then the only modifiable version for rheumatoid arthritis is smoking. So it's been found that smoking can lead to rheumatoid arthritis with age, so as with accumulation of smoking. Now the other 2, the non-modifiable side is that age, in particular for osteoarthritis, is a big key factor, and trauma. So we've got to really consider that if somebody's had an injury to a particular area, or they've had a break, that's the area they're most likely to get osteoarthritis in as they get older. So there's some really key evidence out there that really shows the linear nature of osteoarthritis as we get older. Whereas rheumatoid arthritis is still kind of out there for wherever these triggers are coming from. One person I know, their rheumatoid arthritis came from a virus, an infection that they had, and then as a result, they had the same problem over and over again affecting. That was the guy where the rheumatoid arthritis affected his lungs. So once he had this virus, he had this problem with his rheumatoid in his lung lining continually, whereas some people will have it from birth, some people will have environmental triggers that suddenly mean that that's it, the body just starts to attack its own tissues. So there's lots of different causes that we need to consider here, but if we're looking at exercise referral not only to manage conditions that people have, but to prevent the onset of new conditions, then these modifiable risk factors are really key places that we can be dialing into. Are they doing the right things to prevent these conditions from happening later on? So yeah, nice. So let's look through on the osteoarthritis medications in particular. So let's look through on what types of medications people will take for osteoarthritis. You're going to know these. These are going to be pretty familiar to you. So pain relievers, we've all heard of paracetamol, we've all heard of Nurofen as well. Now, Nurofen is a non-steroidal anti-inflammatory drug. So that's the NSAID. Those types of anti-inflammatory drugs are there to reduce swelling in the joints. That's the main aim for those. There's lots of different types of pain relievers out there, some that have more of an effect on like the gastrointestinal system. So people can feel sick or they can have troubles with digesting those tablets that they're taking down. And you guys might know this from a personal point of view if you've ever taken a lot of paracetamol in sort of like because of the pain that you may have in particular. So they're the kind of main things we need to consider with those. The other side is corticosteroids. Now, these could be on tablet form, but also they might have injection-based steroids as well. Now, these types of steroids go straight into the joint, and they're a really good way of plumping that synovial capsule back out, and that reduces the swelling and it takes the pain right off. So with corticosteroids and steroid injections in particular, we need to consider when those injections are happening, because they're going to have a massive effect on how our client feels. So let's just think about someone that has had an injection in their knee. They've gone from being in a lot of pain to then visiting their GP. GP injects them with a steroid. That steroid basically stays within the synovial capsules. There's not many effects elsewhere in the body. As it stays around that area and it plumps that joint straight out, they almost feel better straight away. Now, as they feel better straight away, they're in a place whereby they might feel like doing more. They might feel like taking more risks. So as that happens, then they're instantly going to feel like doing more. But that doesn't mean that the degeneration isn't still there, and it can end up masking the problem. So we still need to be really careful, even if they say they feel fine. And the same goes if they're on non-steroidal anti-inflammatories or on pain relievers, because this basically sets them up to mask the pain. So we've got to be really careful when working with clients that are under medication, and we need to ask them at the beginning of our session if they're on medication, how much have they had, have they taken it that morning, that type of thing, just so that we know where we are in relation to giving them appropriate exercises and appropriate intensities for that session. Now, if osteoarthritis is really developed to the point that there is a lot of deformity and a lot of severe pain, then they can go down the hip and knee replacement route, which we're going to talk about in a moment in more detail, and they also may be open to some physiotherapy as well. But really, they're the main surgeries that people will have laying out for osteoarthritis. The other side of it is if it affects different joints, usually they're just going to work off the steroid injection that I was telling you about. So in terms of side effects that we need to consider, non-steroidal anti-inflammatories are going to cause some gastrointestinal problems, so will some pain relievers. So it can be really good to make sure you've got a toilet nearby for your clients. So if you're out in the middle of nowhere, make sure your client is okay and happy with the bush, because it may well be that they need to go quickly. Also, we need to consider that with non-steroidal anti-inflammatories, they actually can encourage more of an asthma attack, so they can make asthma worse. Now, obviously, the prescription of this comes down to the GP. That's not our place to intervene, but we need to be aware that even if someone's not had asthma in the past, it might trigger more asthmatic symptoms when they're using anti-inflammatory drugs. And you might know this if you've taken Nurofen or ibuprofen or something similar, and you feel maybe a little bit dry in the throat, or you feel a little bit like tickly cough, that it's the same kind of effect happening around the airways. So looking at the steroids now, any steroid will start thinning the skin. It can also leach out calcium from the bone, so we're looking at an increased risk of osteoporosis. And it can cause muscle weakness as well. So we've got all these extra things we need to think about with our clients. Now, as a result of those, we want to check our medications. We want to check that we've got a toilet available. We also want to check that if they're getting a lot of pains in their stomach from that gastrointestinal problems. Are they really going to want to do crunches and things like that if they can feel a lot of pain in their stomach? I have a different argument about why people maybe shouldn't be doing too many crunches, but we'll look at that on the lower back pain in particular. So we're also looking with those that are taking steroids. Are they using bands, straps, or equipment around their skin? Because if it's quite thin skin, it can be really liable to tear and cause a lot of cuts and bruises very, very easily, and a thinning of the blood and skin. So we really want to make sure that we're looking after them in their whole body and whole condition, not just for the area that they might be affected with their osteoarthritis. So think about what's appropriate and whether they should be having bands and straps directly on the skin. So just think about that kind of consideration as we go through. So there's quite a lot of information in terms of medical. A lot of this has been it's probably fairly common knowledge, common sense in relation to pain relievers and ibuprofens, etc., because we've come across them before. But it's about thinking, how does that affect my client? What do I need to do whereby this can help improve their journey with me as their exercise referral specialist? So really dial in all the time to all these conditions. How does this affect my client? Let's look at the same for rheumatoid arthritis. Now we've got the same. Notice that non-steroidal anti-inflammatories are still in there. Corticosteroids are still in there, and they'll still do steroid injections as well. Now the ones that are different are disease-modifying anti-rheumatic drugs, DMARDs. These DMARDs are a secondary line of treatment, so they're not the first line. So it's usually, if someone's on DMARD, it's a sign that they've had rheumatoid for a little while. Now, if they've had rheumatoid for a little while, then they are at a point whereby they need a little bit extra level of treatment in order to really make them feel much more comfortable in their joints and in the affected area. Now, the way that these DMARDs work is that they aim to promote, prevent them from going into a lapse. So they promote remission from their pain. And what you're looking for is that they, when we're working with them in terms of clients that are on DMARDs, we really want to consider, are they at the best peak performance of their whole treatment routine? So I had one lady that was on DMARDs in particular, and she had rheumatoid arthritis around her hands, and also it affected around her knees as well. And she was in a place whereby she would have 12 weekly injections. So she would basically have injections every 3 months. Now, towards the end of those 12 weeks, she was at a place whereby she was in crippling pain. It was really, really painful for her, and we could do very little in our sessions. However, about 2 weeks after her DMARD injection, she was like the best performance she could possibly be. But straight after, she felt absolutely shot through. So we had to really think about, where is she in that sort of journey of her medications that she's taking, and what does that mean in terms of her exercise, in terms of her energy, in terms of how she's feeling, and also the pain that she's got. So this is kind of a main thing to consider if they are on these kind of disease-modifying anti-rheumatic drugs. If they get to the point of surgery, this is something that obviously can only happen in joints. It can't happen in terms of lining. So if they get to the point of surgery, generally that involves something like a replacement if it's that particular area. However, because it is rheumatoid arthritis, it's affecting in the body itself, in the blood itself, and around that lining. We really need to be really sure that if they're going into surgery, there's probably other problems going on in that same area, like some osteoarthritis or some wear and tear going on. They're also going to go through physiotherapy and occupational therapy quite often to increase their range of movement. And this is a great opportunity for you guys, because you can start working alongside these people and alongside their osteoarthritis and alongside their physios and their occupational therapies, just to make sure that we're giving them the best we possibly can. So we're going to look, so the side effects of these in particular are gastrointestinal problems we've spoken about, thinning of the skin we've spoken about. The disease-modifying anti-rheumatic drugs can cause some hypertension, which means they can go up in high blood pressure, obviously. The exercise response as well, that we need to consider. We were talking about gastrointestinal problems earlier. We were saying about bans on the skins for steroids. And then, like we were saying with disease-modifying anti-rheumatic drugs, if they've got high blood pressure, then we need to consider the contraindications and the considerations for someone with high blood pressure. And the same with any coexisting conditions that our clients might have. And the other side of that is obviously consider their peaks and their troughs in how they're feeling in relation to their medication treatment process, and also just how they're feeling on that day. So these are some major differences that we've got on our rheumatoid arthritis and osteoarthritis. let's have a look at what we actually need to do. So now we understand it, we can look at what we need to do as exercise professionals, and how this kind of works for us. So from a lifestyle intervention, we're looking at weight loss can help both of these conditions. Really important to consider that weight loss in general is going to help take the weight off for an osteoarthritic person, and also in reducing the weight generally, but the demand on the body for the rheumatoid arthritis. So they both work really well. The other things that we need to think about is just general levels of activity can help. It doesn't have to be high intensity. In fact, in most places, it shouldn't be based on the conditions that your client has. It should actually be something that allows them to create synovial fluid for the osteoarthritic people and allow them to just keep moving for the rheumatoid arthritis. So it's looking at how do we maintain where they are and improve the best that we can. Just gentle activity is perfect. Now there's also a comment on here. It says glucosamine sulfate and derivatives are a good thing to suggest. I'm of the belief that we should not be suggesting any kind of supplements to our clients at all, and that they should be looking to get everything that they need in their nutrition. And alongside that, all their supplements are probably going to be given to them by their GP. So if the GP thinks it's good for them to be taking additional glucosamine or chondroitin or whatever it is that they think might be best for them, fish oils, omega-3s, whatever it might be, to really help along those joints, then really that's their place to do that as a GP, not our place as a fitness professional. Now, however, you can give them help and advice on their nutrition, and we know where they can get those omega-3s and 6s from. We can suggest things that may well help them, but it doesn't necessarily mean that we should be suggesting supplements in particular. So I threw this one in here just to kind of throw that out there and bring that up as a point. Even if you find it's helped you or it's helped other people, avoid offering out supplements or recommending them, in my opinion. In terms of the benefits of exercise, we've gone through this a lot already, in that it's all synovial related for your osteoarthritis. If we can lose weight as well for our clients, that's going to massively help them from having all the weight going through those joints in the affected area. We want them to have functional movement, and we also want to reduce the risk of any other problems they might be having further down the line, like coronary heart disease or any other back pain or postural problems that might be caused as a result of them having these conditions. So we're able to do both. The other side for rheumatoid is that we really want to look at stabilizing the joints even when they're at bad times and at good times, so that we can work alongside those peaks and troughs that they have. Okay, so I just want to go through the exercise guidelines really briefly for these two together. So this is for osteoarthritis and for rheumatoid. They both get treated the same in terms of our recommended exercise guidelines. So we're looking at the very similar recommendations as to the health-related guidelines. Now, alongside that, notice that they say in the resistance training, in particular, they say start with 2 to 3 reps and build to 10 to 15. Now, endurance rep range is great, endurance intensity is great, but they might not manage a full set of 10 to 15 repetitions, which means that we need to be considerate to the fact that people that are very high on their osteoarthritis and rheumatoid arthritis and very affected, we don't want to do like 15 repetitions of something that might be fairly harmful. So we're going to just do a couple to start off with on their first couple of sessions and build it up on every single session that they're with us, as long as they don't come back saying that they were in crippling pain afterwards. So this is a really, really important point to consider, and that's right here in the middle on time, on resistance. Start off low on your repetitions, just for one set. It might seem like you're doing hardly anything with them on that first session, but that's fine. Let them go away. Let them give a review of how they feel. Is there any more pain in that area? Are they feeling comfortable? And then as a result, when they come back, you then add on a couple more reps if they're feeling good. And then the next day, add on a couple more reps. This is much more effective than jumping straight to 15 reps on every single exercise and then wondering what on earth caused the problem that they can feel. So we've got to take it really gently, and even if it feels like you are doing very little amount with that client. So we want to make sure that it's not just a case of filling an hour session with our clients, but that it's actually more about, are they able to benefit in the best possible way? And that's what we're looking for. We're looking to make sure that they are still doing 3 to 5 days a week of aerobic training, because it's going to help. But we want to consider what type that they do in relation to keeping it low impact, especially for osteoarthritis. If we can keep that impact right down, then our clients are in a place whereby we're not making their condition worse, which is obviously the desired effect. We want to make sure that we're keeping them comfortable the whole time. So think about range of movement on all exercises. For example, if they've got osteoarthritis of the knee and we put them on a bike, can they do a full cycle of the bike? Can they make their leg go around that whole range of movement? Or is it causing pain? In which case would they be better on a cross trainer? Do we need to think about the cross trainer in comparison to the treadmill in terms of impact if they want to get up intensity? So think about the type of thing that you set them compared to the area that's most affected and what they feel comfortable doing. This really means we need to dial in to their RPE, but also their pain scale the best we can. Now, a pain scale is perfect. On a scale of 1 to 10, how much pain are you currently in your associated joint? So that might be 10, call an ambulance, I'm in excruciating pain. 1, I could do this all day long, I feel fine. And you literally need to be able to kind of get them to reflect, where do they feel in this pain scale, because it gives you an idea of how far you want to go with them. Certainly wouldn't be going above a 7. That's kind of the rule of thumb. If they're going above a 7 in pain, then it's a sign that they think it's too much. Now, obviously, this is subjective. This is all in their mind, really. It's their perception of whether it is too hard work or not. And we need to listen to them whilst they're reflecting on their body. So the other side of that is to gradually increase range of movement. For both of these conditions, we need to be doing flexibility training, but we just want to take it to mild tension. So we're not going to push them past their capabilities, because remember, it's not just the muscle that we're stretching, it's also the range of movement in that joint. And if you think they've got bony spurs maybe going on, or they've got a lot of swelling, we don't want to force that beyond what they're capable of. So just to the point of mild tension, nice gentle developmental stretch on that area up to about 60 seconds or so is absolutely perfect, and ideally done daily. So there are our main guidelines for osteo and rheumatoid. Now, before we go on to asking you a couple of questions, checking how you're doing, I just actually want to see what your main things that you've learned so far in relation to both osteoarthritis and rheumatoid arthritis. So I can see a couple of questions coming in as well. So alongside, if you just pop a little comment in the chat box on the main things you've learned so far in relation to these conditions and in relation to dialing in to the difference between osteoarthritis and rheumatoid arthritis. And I'll just take a second to look through your questions before we go on to the next part. So let's have a look. So the questions we've got coming in. Lovely. Does a lack of vitamin D play a part? So I'm not sure if this is in relation to rheumatoid or in relation to osteoarthritis in particular, but vitamin D has not been shown to be a cause or effect of any of these as an outstanding amount. It can relate in with osteoporosis, which we'll look at later in relation to the right vitamins that are going into the body and how that affects calcium absorption. But that's osteoporosis in terms of the porous effect in the bones rather than for rheumatoid in particular. So just a little bit of clarity coming through that vitamin D in relation to rheumatoid. I've not had any fast evidence that shows very specifically that rheumatoid arthritis is affected by a lack of vitamin D. Just to kind of throw that one out there. So what's our biggest learning curve in particular for you guys? What's the biggest thing that you've learned in relation to osteoarthritis and rheumatoid arthritis? Just take a second to consider those. I've had one come in saying that rheumatoid is immune. Yeah, absolutely. Most people don't even realise that rheumatoid arthritis is an immune condition and that it's very, very different to osteoarthritis. Most people just see it as arthritis, and therefore we assume that it's all osteo. Very, very different. Love that. That's fantastic. Okay, so now let's have a little look at what we need to do in terms of what we are considering in terms of exercise. What considerations do we have, and also what restrictions do we have? What can't we get these clients to do? So let's have a look at considerations to start off with. We want to promote mobility and flexibility. I think that's a given, but we shouldn't be putting them through pain in doing so. We want to strengthen the muscles all the way around the joint, but without putting too much pressure on that joint. So we might, yes, want to do isolation work to help support, say, the quads when they've got a knee osteoarthritis. But at the same time, we don't want to put too much pressure or too much demand on that joint that means that we make the condition worse. There's a fine balance between where their pain sits. We want to extend warm-ups and cool-downs because it gives them more time to allow that synovial fluid to get moving. So if that synovial fluid is really starting to warm up, or it takes a bit longer, extend that warm-up. Have plenty of mobility exercises in that warm-up for anything that's arthritis-based. We want to make sure that our clients have the right footwear. So if they've got the right footwear whilst they're exercising, then that's going to help with shock absorption and stability and posture, because if they're rolling in massively because they've not got the support from their shoes and they've not got the strength to be able to hold that themselves, then we're going to be making it worse by exercising on poorly aligned joints, and that could definitely make osteoarthritis worse. If your client, for both sets of arthritis, it can be really good to consider the time of day that your client is exercising, because they are more likely to be more comfortable later on in the day. So avoiding that kind of stiffness that they might have in the morning in the joints. So really think about exercising later on in the day if your clients have arthritis, because it will make them be in the best place possible, ready to go. One key point is to progress duration over intensity. So we want to work on our programs with our clients. If you imagine an 8-week program and we had to divide that into 2 things, we would first work with getting them to just move for longer, even if it's not a more intense state. So they might stay at 50% of their max heart rate for the whole time for those first 4 weeks, but we gradually get them to move for longer at that time. And then for the next 4 weeks, we might start working on their intensity at that same duration. So our priority must be duration over the intensity. And the reason for this is if we take the intensity up too high, say that now takes us to running or sprinting, our osteoarthritic people are now going to be at a point whereby there is a lot more impact. And our rheumatoid arthritis people might not manage that step up of intensity in relation to the trigger for their actual rheumatoid arthritis flare-up. So they're the key things to consider with the actual duration over intensity. We need to be really sensitive to their emotions as well. And this kind of sounds a little bit out of place when we're talking about joints. But remember, they could be on medication, which can affect that anyway. They also just may be feeling a little bit overwhelmed, a little bit kind of useless compared to who they used to be. So if you take you now, super active, fit pros that are doing your thing, you literally feel great. You feel like you're moving, you feel in control of your life. If you take away the availability for you to move as easily as you want to do the sports that you want to do the running, to do whatever it is that your hobby is, you take that away from you, you're going to start to feel not like you start to lose your identity. So we really need to be sensitive to where our clients are on an emotional level and do the best we can to help them. And then the final consideration is functional exercises. Goes without saying, they don't need to be getting better necessarily at leg extension. They need to be getting better at getting out of their chair, or sitting down on their chair, or going up steps. What is it that they can do that is most like what they'll do on a daily basis? And then that allows you to prepare them for life. And at the end of the day, that's what we're doing. The exercise referral, that's our main focus. Get them moving and increase and improve their quality of life. Things we need to consider is that if we really make this very strenuous on our clients, it may cause flare-ups, in particular with rheumatoid arthritis. If this happens with osteoarthritis in particular, they're going to get pain afterwards and potentially during. With either of these, if your client reports pain that lasts for more than 2 hours after their exercise, this is here on the right hand side of my screen, more than 2 hours after exercise, or that their pain progressively gets worse after the session, then we know we've done something wrong in that session to affect them. That is really crucial information, because we can then adjust what we've done and go again. And if that's causing an effect again the next time, even after we've adapted and adjusted and regressed that exercise, then it's now time for us to refer to a GP. So I would always give it a couple of sessions whereby you're trying to take it back and seeing if that makes a bit of a difference. And generally from experience, it does. It makes a huge difference, and their confidence goes up in their ability to do it. And then if that really isn't making any effect, or it's making things worse, then we just need to refer them back to the GP, because it's a sign that there's something very dangerous going on inside, or there's quite a significant amount of joint damage happening. And obviously your client may now need to do something else, because at the end of the day, if they can't walk on a treadmill without causing lots of pain, or they can't do a few gentle squats without causing lots of pain, then this also says that they're very restricted in their daily life too, and we don't want to be making their condition worse. We just want to be helping them. So then the other restrictions we have, so these are your absolute no-nos, okay? So if their grip is affected, we do not want to be taking really high grip levels. This is particularly for rheumatoid, but definitely for osteo as well. If their grip in their hands, then think about what can they grip comfortably. Maybe you could fill a pillowcase full with soft or like sort of we used to do this with sand in particular, pillowcase full of sand, and that allows you to then to hold that and wrap that around rather than something hard like a dumbbell. Also, something like a foam ball or a medicine ball is easier to hold if people's grip's affected compared to a barbell or a dumbbell. Just had a comment through saying about actually wrist weights are great. Definitely, if they've got problems gripping, use some wrist weights. Also, we want to prevent any kind of extra discomfort on that area. So if their problem is knees, then we don't want to kneel on those knees or put lots of pressure right directly onto that area. If their problem is wrists, then we're not going to be doing press-ups or plank, because that's a lot of excessive tension on that area. And there's other exercises we can do that will avoid that whole pain altogether. So just put in an alternative. Other things to avoid: really high impact exercise. Avoid excessive repetitions. We said about this a moment ago, so that you're choosing kind of 2 to 3 repetitions rather than 15 straight away, and you can just gradually build it up. Similarly, you don't want to do a massive amount of duration on their first session if it's CV, because you don't want to kind of keep that problem going. You want to build it up gradually. We want to avoid kind of fast-paced movements. Often that's related to impact or poor form. And obviously we want to avoid contact sports, but also that change of direction that happens with those types of sports as well. So consider where they are with change of direction and joint stability. Always dial into the amount of pain that they have, and always consider the side effects of their medication. Consider how they are feeling on that particular day. So how are they feeling? Okay, great. So let's, I'm going to pop it on this screen, and I've got a quick question for you guys. So let me just have a look at one of the questions that has come in before I let these in. So let's have a little look at these questions that are in here. Just 1 second. Lovely, great. Okay, yes, absolutely. So I'm glad you guys are feeling nice and confident throughout all of these. That's really great. So let's have a look. This is the question I've got for you guys. So if you look at your screen, you'll be able to see this one appear. So here is the question. Lovely. So hopefully you can see the question up on your screen. So these are about the priorities for rheumatoid arthritis. So what I need you to do is just vote. You can click on these as many times as you like. So you can click on as many as you wanted. So you literally go to the poll that's directly up on your screen, and you can click straight in there, select as many as you want, But which of these are considerations for rheumatoid arthritis in particular? So which of these do we need to consider? Lovely, so we've got some votes coming in. So which of these do we need to consider with rheumatoid arthritis? Ah, this is interesting. Okay, lovely. Keep going with these votes. So we're getting, in particular, a lot of people saying whether they're having a good day. Fantastic. That's really what we're looking for. That's probably one of the main ones. Is it a good day for them? Now, this is quite commonly people overlook this one because they go, oh, okay, are they having a good day? That's not really relevant. That's just about their emotions. It's not just their emotions, it's about their energy. It's about whether it's remission or peaks and troughs that they might be having. We do want to consider bone-on-bone wear and tear, but really that's for osteoarthritis. So in particular for rheumatoid arthritis, time of day to exercise is really important, and also to include gradual range of movement progression. So you should be having these 3 central poles. So that's what we're looking for, these 3 central answers on the poll. So time of day to exercise, whether they are having a good day, and whether they include gradual range of movement progression. So that's what we're looking to do with these particular clients. So nice one, fantastic. So that kind of was a 2-minute little poll. Nice to see that most of you all went for whether they're having a good day. That's probably the main one I was after, so massive well done. So let's head straight back in. And it seems like you're all feeling pretty confident in relation to the rheumatoid arthritis and osteoarthritis. Now, it's really important that we have good basis here, and that you kind of can understand what's happening, because we're going to move on to talking about joint replacement. And joint replacement is really going to be the point whereby they get to from having lots of deformities or degeneration, especially from osteoarthritis. So it is most common in hips and knees, and they're the 2 we're going to look at in big detail. But this doesn't exclude you from working with someone with a shoulder replacement, or maybe even a spinal operation. So we're looking at what is it that they've had replaced, and why was that? They're kind of really important points. So what surgical procedure has been carried out basically on that diseased joint, and what kind of artificial replacement has gone in. This also might cover us for working with clients with amputations as well, and really this covers whether you feel comfortable to work with those types of clients and their prosthesis and how we're working with them. But we're just going to look at hip and knee in particular, because 72,000 hip procedures pretty much every year, and it is on the way up because we're getting even more older populations, even more problems as we're getting older and our life expectancy increases. We end up with even more problems going on, even more diseased joints, even more osteoarthritis, even more falls and fractures, and then more hip procedures being completed. So I do have some videos for you, so if you are a little squeamish, it's okay, they're animated, but it's worth kind of considering. If you are a little bit squeamish, you might want to look through sort of half squinted eyes. So let's first of all work out about our signs and symptoms, or why they have a replacement in the first place. It's only if they've reached absolute deformity and a lot of pain. So if they're in this place whereby they have a lot of deformity and a lot of pain, then it can be worth them having a replacement. Now, I've had a lot of clients post hip and knee replacement, and I have to say there is a lot of complications that can happen. There is a lot of examples whereby the people that I've been working with have literally had a worse outcome from having their replacement, which means that it has to be that they are in so much pain that they're at the point whereby it's the best option, whereby it is an improved quality of life regardless of what happens in that actual intervention, whatever happens in that operation. The new joint can be really unstable, and it can be really prone to dislocate, so we need to be quite considerate about what we do with our clients. It restricts some of the exercises we can do with them, and we need to make sure we're working on stable movements with them, and not expecting them to do anything very bizarre straight after their operation. They must have rehabilitation, so they will usually be signed off by their physio, usually about a 6-week intervention that the physio will have, but it might be more, it might be less than that, depending on the client and whatever happened to them in surgery. Now, as a result, we only want to be working with someone that's had a hip replacement or a knee replacement after they've been signed off from an osteopath or a physio, usually their physio. At this point, we know they've gone through their whole rehab process and they're ready to carry on moving with us. And we can use all the notes, all the exercises that they had with that physio, and now start developing those into a more functional approach, ready to let them help them increase the quality of their life. Normal functioning should be possible after 6 months, but we still need to be considerate to the fact that it is a vulnerable area. It's bionic, at least. Also, we need to think about the lifespan of a joint replacement, which is why it generally happens in older people. So older adults are generally the people that are going to have a replacement. And the main reason for that is because if it only lasts 10 years, they've then got to go back in and do that all over again, whereby that wear and tear comes all the way back round again. There are some various different operations that are available now, like a Birmingham resurface for the hip, for example, and that generally is easier to take back out and then bolt on another resurface rather than ruining the whole femur again, for example. So we kind of got to think about where our clients are going to be. If they've got a joint replacement, they are likely to be older. They're likely to already have stability issues. So what caused it? They fall over, and if they fell over and had a fracture, is that a result of low balance? Or did they have a fracture because they're osteoporotic? So we kind of got to really dial into these differences. Now, I'm going to go through these videos with you, and we're going to start off with the hip operation. I'm going to be totally honest with you, it isn't too bad because it's an animated. That's why I chose these videos in particular, because I've had a few people pass out with me when I've done these, and they've shown the real life ones, and I wouldn't want you guys to do that. So if you are a bit squeamish, you should be fine, but it can highlight the imagination a little bit. So if you need to look under censored eyes, then I totally understand. There is no sound to this, so I'm going to talk you through them as we go through. So let's wait for this one to load up. Fantastic. Okay, so you can see on here, hopefully you can see the screen fine still. Now this is for our hip replacement. So when they're laying down, literally this is done from a side-on position. And the incision is made all the way down through their abductor, so it's literally happening right across the side of the glutes. So think about all those muscles that they are cutting through. So there'll be the initial kind of opening of the skin, then they're going to cut right through these muscle layers. So already our little highlight, just thinking about that bit in particular, is that we now need to think about what damage have they got happened to those muscles. Because if they're really damaged on those muscles, then our priority needs to be regaining the strength of the muscle that has been cut through. Now this is the bit that generally people get squeamish on. They literally manipulate the leg to dislocate so that we now have the femur separate from the hip itself. And whilst that's now been dislocated, we can remove the femoral head. So this is where the surgeon will remove the whole end of the femur. And then from here, they want to clean out the acetabulum. Now this whole cleaning out process is to get rid of all those deformities. And actually you could really see there how bumpy that was based on the arthritis that was there. Cleans it all up so it's a nice smooth position all the way around that acetabulum now. Now, this is a bit where people generally get a little bit squeamish. Let me just pause it there for you. This metal rod is going to go all the way down through into the marrow of the bone. So it's got to go all the way down the center of that long bone. Now, the aim for this is for stability, because if we just now bolt a little bit on the end, the chances are that it creates a weak point. So we're creating this kind of like fence post that goes the whole way through their bone. Now, the thing that they need to be mindful of here is that if that client is very osteoporotic in particular, so they have a lot of, they have very very porous bones or very delicate, fragile bones, then they're in a place whereby this is really likely to fracture. And actually, I know one client that I only saw her after her operation, but she had, when she was on the table, her femur was fractured in 3 places whilst on the table with her client, with having her operation, and that meant that she was actually in cast the whole time after this point. So it meant that she was in a place whereby she sat in a wheelchair with her leg out front, and her quality of life was massively diminished after the hip replacement because they'd fractured the femur. And actually she died 6 months later, but she didn't actually make it to kind of ever being able to stand up on her hip replacement because it went so wrong for her. But generally there is a good success rate. So let's keep playing this and watch them put down the preparation through the femur. So this is them preparing it. So you can really see them go right into the long bone of the femur. And as they're pushing all the way down through, you can see the marrow starting to expand. And they expand to allow that space, and then they can put in the prosthesis from here. So this prosthesis is going through, or they're going to do the socket first. They're going to do the socket first. That's fantastic. This can be different. Sometimes it's made of metal, sometimes it's made of ceramic, and sometimes there's a plastic lining on there as well. So we need to kind of consider what type of condition that might be in. Has it been a long time since they had their hip replacement, in which case is it starting to corrode or starting to cause problems? Then they knock in the actual part that goes into the femur. So they're knocking that in the whole way down through the femur, and they stick a ball on the end. Now, I've kind of got a little sad story for you on this one. The ball that they put on the end here will vary in size, hopefully based on the socket that they've fitted in relation to the person that's having the operation. Makes sense, doesn't it? However, I went to a convention, and at this, it's a musculoskeletal convention for doctors, but me and Neil were sat in the audience, and I always love telling this story, but we were sat in the audience as probably like the only fit pros there, geeking out on musculoskeletal stuff. And literally they were saying that, well, we always use a smaller one, but the problem is that then it might dislocate, and then they've got to come back and they've got to get it refitted. And we're like, well, why are you using a smaller one first? Why don't you just go for the right sized one to fit? And they go, well, it saves money. So the whole reason for them putting in a smaller ball was so that it saved money. It was less materials to pay for. However, in doing so, it often meant that it was a dislocation that meant that they had to go back into operation again anyway and get it reset. So there are issues with that, but your client might be prone to having dislocations based on the size of the ball that they put on the head of the femur here. So then that ball then goes back into the socket. They relocate the hip back on, and then from here they are all ready to be sutured back up and ready to start fixing again. It's important that they start exercising or weight bearing almost straight away. So usually they will weight bear within 6 weeks. So now this is all tidied back up and they close up the skin. Lovely, lovely, lovely. Okay, fantastic. So that's our hip replacement. So on this hip replacement in particular, let's have a look. Fantastic. Just seeing if you guys have sent in any comments based on these. Lovely, great. Okay, so on these hip replacement in particular, it's quite brutal, and you guys might have noticed just how brutal that kind of is. This is done generally awake because they need to make sure that there is no need to put them under. However, that will depend on the status of that client and then their safety aspect of them going under. But that means because of the brutality of it, they're going to feel things moving during it. So it is quite important to dial in and just be appreciative for the fact that your client has gone through a serious amount of hard work. They're going to be bruised, they're going to be sore, they're going to be swollen, and they're going to feel pretty weak around that area. But at the same time, they're going to feel so much relief because now they're not getting that wear on tear feeling, that grinding every time that they make a movement. So they might feel the best they've ever felt. And I've actually got a really funny story. One of my clients, we used to call him Grumpy John for the obvious reason he was grumpy. but he had really bad osteoarthritis in his hips, and he always had his feet turned out at 10 to 2, like continually. And he was doing like, we found it very hard to get him to do squats and stuff towards the end. And then he went on and had his hip replacement. And suddenly we couldn't call him Grumpy John anymore. He was absolutely elated. He felt really, really great that he was able to sort of feel without any pain again. And that meant a lot to him. And he wasn't grumpy anymore, which is great. That's a brilliant part of the story. However, one of his feet was pointing forwards and the other one was pointing out at 10 to 2 still. So he was continually in this strange location whereby they'd set his hip on a slightly different angle to the other one, which meant that he was, whenever doing squats and stuff, he could only have one pointing forwards and the other one out to the side. So a nice little light-hearted story just to bring that one back. But let's have a look at the knee replacement as well, and then we'll see what you guys think about these. So just let's go on to the knee replacement. So knee replacement. Now, commonly, the knee replacement, there's a lot more problems that happen with the knee replacement because it's so much more complex than what happens with the hip replacement. Hip replacement just has one ball and socket. There's a lot less complications to happen. But from my experience as well of working with these guys post-operation, much more complications post-knee replacement. They don't always return back to full range of movement. And that can mean they're either stuck in a flexed position or that they're stuck in an extended position, and that can cause a problem for us for exercising with them. So let's have a quick look through this knee replacement as well. Now, this is obviously done with a very identifiable cut all the way down through the top and front of the knee. They then need to move the patella out the way and the patella tendonitis. Patella tendon, they might well clean that one up as well. But then they need to put in their guidance and they cut through. So can you see like the wear and tear on that whole femoral head as they're cutting through? So this is the femoral condyles. This bit that they've cut away is what we class as the femoral condyles. So it means the condyles of the femur. These are like the two ball points that sit on top of our tibial plateau, so on the very end of our femur, basically, for our knee. So they have cut away this point that has the most amount of movement on it, the most amount of articulation. So notice all that cartilage goes with that as well, everything that's on the outside. And this little contraption is a measuring device to make sure that they're cutting off the front top part as well. And they cut off around the bottom part, and this is just making sure they're measuring it all in correctly for them. This looks seriously butcher-esque, doesn't it? And very, very specific. So, but you'll notice when they pull this away, we don't have to learn how to do this, you'll be very thankful. It looks just like a smaller version of what was there originally. And then they need to prepare the tibial plateau. So this point that they're cutting through here is on the top of the tibia, so the bone of the lower leg, and they're going to cut the tibial plateau off entirely. So as they cut all the way through here, remember this is a full knee replacement. Some people just have top, some people just have the bottom. Then they can prepare the patella. Some people might not need it, and they literally can cut out the inside of that. So now you've got nice, smooth bone surfaces the whole way through. And then we're going to attach the condyles, replacement tibial plateau, which is usually plastic related on top, and then they can even put the end of the patella on there as well. And then literally they just need to tube it up and make sure everything's in place and then close it all up. So very similar to the hip replacement in that they're replacing both sides where the problem occurs. So as a result of replacing both sides, they're going to have pain throughout it all. So we need to kind of consider that element of it. They're going to have pain both in anything related to, say, the quads, but also anything relating to the anterior tibialis and the calves on the lower leg and the hamstrings. So we want to think about the whole area plus or minus a joint. This is how I like to look at it. That one joint plus or minus one joint that might be being affected. So, for example, if it's a knee that's been replaced, I want to be considerate of any movements that I then put the ankle through and the hip through. So think plus or minus. If it's the hip, I want to be considerate of anything that I do in the torso, in the spine, and the motion around the spinal flexion and extension, but also around the knee. And that means that I'm really considering the stability of that joint and not just looking at it in relation to the one joint moving, but also the entire kind of motion of that whole movement. What is it affecting? What is the knock-on effect? So I'd be really interested to hear your feedback on these videos that you've just watched of the replacements. You'll be really glad to hear that you do not, so just pop that in the comments chat box now. What have you noticed in relation to these? What were your biggest kind of takeaways from these actual procedures? Now, you'll be really glad to hear that you do not need to know how to do an operation of one of these on your clients, but you do need to kind of have a bit of empathy about what they've gone through, and it's quite a lot. And yes, it is savage. It really is a savage hip operation. So think about what they've been through, and in relation to the types of exercises you're going to give them, it's not just, oh, have a little injection straight into the joint. They've gone through quite a lot, and both of them are very savage. So from experience, you will know, I've found that the knee operation doesn't have as great of a greater range of movement after, which means that sometimes they can't fully extend, sometimes they can't fully flex. So as a result, we need to be really open to adaptations that they might need to do, like for example a bike that they can't then go full cycle around on that bike, or can they walk effectively and evenly? So you've got all these things to be thinking about in relation to posture and technique and how they move on our equipment and how they move in an exercise as well. So a couple of comments coming in about didn't know before that the hip replacement and the knee replacement are both done under local anaesthetic instead, and yeah, they are savage, absolutely savage. So good to kind of throw those out there and really understand what our clients go through. I'm glad you enjoyed the videos. So let's look at what these risk factors are. Why are they going to need to have a joint replacement in the first place? Osteoarthritis is the key one. Notice all these are modifiable, by the way. They're totally modifiable. There's no non-modifiable reasons why. Osteoarthritis is the main one. Wear and tear obviously is very similar with osteoarthritis, but it can kind of come in relation to injury. The other side could be something like a fracture. So if they've fallen over and they've had a fracture to the hip, which is really, really common if someone's got osteoporosis, which we'll look at in a moment. And as a result, that fracture can then mean that they need to have a total hip replacement just to tidy it up and get it stable again. Then chronic obesity is obviously a main reason for getting osteoarthritis, and then osteoarthritis can lead to joint replacement. So these kind of all bolt onto each other, and you can really see the route that your clients are going down, so that they might start off perfectly healthy, just a little bit overweight, and then suddenly they start getting pains in their knees, and that goes up into their hips and their ankles and their feet, and then that pain gets worse in their knees, and now they need a joint replacement. And I'll be brutally honest with you that there is a very poor success rate and life expectancy after a joint replacement, in particular after the hip replacement, because like you said, it is so savage that some people just can't deal with that. So up to about 6 months later, generally there is this curve point whereby people don't survive after a joint replacement. Very good point just come in from Michelle, and that's that with knee replacement, they're not really going to be able to kneel down after that. Absolutely. They're not going to want to put that pressure straight on that joint, even 6 months post that, because it's a lot of pain going right through that point. So think about, are we making them do things like press-ups while they've got to come down to their knees, or how do they get up off the floor? How can we teach these people to get up off the floor if they've got joint replacements or osteoarthritis? And this is something to really dial into about how do you teach someone to have the functional benefit of actually getting up off the floor the whole time. It's a really good thing to think about. Okay, so Let's look at medical interventions, and you'll be glad to hear these are exactly the same as what we've already done for osteoarthritis and rheumatoid arthritis. So it's going to be the normal anti-inflammatory drugs, normal paracetamol, steroids and physiotherapy. These are the main kind of medical interventions. We've already looked at what that involves, so I'm not going to go through these again, but just bear in mind they could still be on the same medication as they were when they had their osteoarthritis, and now even though it's healed, they're now going to gradually come off those, and some pain relievers can be addictive, so we've got to consider that fact as well and how they might feel coming off those. There are no specific guidelines for joint replacement. So in this table, they are literally just the healthy adult table that we use with our healthy clients in order to get healthy, to be healthy, fit, and in good condition and prevent these conditions from happening. It's the same recommendations, same ACSM guidelines as we would for after a joint replacement. This is really intuitive working with a joint replacement because you don't want them to be in any pain. They've already gone through physio, so they know roughly what they're capable of, and they'll be able to show you what exercises they've done in physio and the range of movement they can get. And that's your first place to start in your programming. So as you're working with them and they go, oh, I've done these little sit to stands, and then I've done these straight leg stretches, or whatever it is that they call them, as they're starting to go through them all, you can go, okay, yeah, lovely, right, we're going to use those and we're going to gradually start to build on them. And just look at it as very logical and progressive. Use your normal intensity scales, your normal variables. How are you going to change the range of movement, the resistance, the repetitions? How are you going to make it harder for them? How are you going to hold it for longer, etc.? So change those variables very gradually to benefit them and progress them. Okay, so these are our considerations and our risks, the things that we really need to dial into. We need to consider the emotional impact. That's a given, I think, based on what we've just seen happens in those lovely videos. We need to include any exercises for all actions at the affected joints. So think about, we want to work from a flexion point of view, an extension point of view. If it's the hip, we want to then be working with rotation, circumduction, abduction, adduction. We want to really be working through all joint actions so that we can really gradually mobilize and strengthen. Sounds like a plan, doesn't it? Then gradually increase the range of movement and resistance, and that's really gradual over time. Promote their flexibility, and then you want to strengthen those muscles around the joint without overbearing the joint or pushing them too much too soon. So gradually increase that resistance and strengthening those muscles that affect the joint. Certainly don't avoid that area as part of their plan. So say someone comes to you with weight loss and they've had a knee replacement, don't avoid doing anything around the knee because they experience some pain there. They're actually going to get better results if we can start strengthening that muscle so they can use it properly. So even if it's their secondary goal, don't avoid the joint, make it a key part of their programming to help rehabilitate it and take it to the next level. Exercising in deep water, this is a really important one. Water exercises are actually really great for exercise referral. Now, I don't necessarily mean going to aqua aerobics because that depends on what it is that they're going to make them do in that session. I can't guarantee what that class instructor will get them to do. But if you think about waist height water, waist to chest height water, and doing walking up and down in terms of walking the length of the pool and back, these are really great because they take the weight off of the joint, which causes less pain. This is also good for osteoarthritis as well, by the way, but it also allows them to move and get movement in that joint and allow them to add gentle resistance to that joint and to their muscles. So it's really beneficial. The only thing is to take it very gently to start off with, because whilst the weight is off the joint, they can't sense the pain. And then as soon as they get out of the pool or the next day or a couple of hours later, they might be in a lot of pain. So we want to gradually increase and not go too much too soon just because it feels okay. Our biggest risk with these guys is that they dislocate. So not what we want. If your client has had a replacement and they dislocate their joint replacement, then our immediate thing to do is to call an ambulance. We do not need to be dealing with anything or trying to put it back in. You want an ambulance to come and sort that one as soon as possible. So, and they're going to be in a little pain again. So then the restrictions that we're going to have to consider here is the level of pain. Make sure they're not going above a 7 out of 10 in terms of the pain that they experience on a pain scale. Although some things might be uncomfortable, dial into the difference. Is it uncomfortable or is it painful? Now, this is a perception thing again, but make sure that you have this really frank conversation with your client. Is this uncomfortable or is this painful? And is this uncomfort a sign that we're making things worse, like kneeling on a joint replacement, for example? Or is it a sign that it's just a new sensation, it's something new, and it should be okay? So think about, is it uncomfortable or is it painful? And dial into those differences with your client. Avoid pain wherever possible. Offer the supported options where necessary. So if they are doing a balance, for example, or doing something, is there a way that they can hold on to a wall? Can they be supported? Can you support them and then gradually reduce the reliance of that support so that they gradually build their confidence and they also gradually improve, say, their balance and their stability as well. First session, definitely don't leave them on their own to do a one-legged balance, basically is what we're saying. We want them to have limited abduction and adduction. So think about these two movements. So if you think in particular for a hip, this is for a hip replacement. So if you take hip adduction, adduction is when you're taking the leg from out to the side and bringing it into the middle. Now if we take that past the midline, so we're basically crossing our legs, or if you're sitting down, crossing your legs over, either like a lady cross position or even like a man cross position where you totally open up the leg, that's a massive no-no, because in that position the hip is the most open it can be. Now in that position they're most likely to have a dislocation. So this is extreme abduction and adduction. Now if you think about that hip operation video that we just watched, when they had to dislocate the hip, they basically abducted the hip massively, as I did that here on my hip click. That's not good, is it? So as you do that, they get past massive abduction, i.e. taking the knee away from the midline. They're going to potentially cause a dislocation. And this is something like a traditional lying glute stretch. So if you think about a traditional lying glute stretch, that position, that abduction of the hip, is a big no-no to push through an excessive range of movement. Also, we want to think about excessive adduction, so that crossing of the legs is a no-no because it can still cause dislocation. Then another big no-no, so you've got lots of things to think about. Another thing that is a contraindicated exercise is that if they have hip flexion more than 90 degrees. So there is two ways of doing this. You can either be sat up, so if you're sitting in your chair at the moment and you reach down to the floor to get something from the floor, you're instantly reducing that angle in your hip to less than 90 degrees. Now as soon as that goes less than 90 degrees, the hip at the back and the joint in particular at the back is less stable. So certainly up to 6 months in, until they get to the stable point, we need to be avoiding excessive flexion of the hip. And that can also happen from, say, if we're standing and we pull the knee all the way in towards the chest, or even if we're lying and we pull the knees into the chest and we get that excessive flexion, then that's a no-no because we can cause dislocation. Any kind of swiveling or like moving around whereby we're rotating in a way that the joint isn't designed to move is a no. So think about those. When we're looking at knee and hip, avoid the breaststroke swim action for the legs. It doesn't matter about the arms. We're looking back for the legs because it's a very unnatural position. It goes through a lot of abduction and adduction, which can put it under a lot of stress and obviously cause dislocation. And finally, consider the effects of those medications, the emotional side of it as well. So throw all of those things together and you have quite a list of some contraindicated exercises that we've got to consider with our hip replacement and knee replacement clients. So I've got another question for you, and for this one, let me pull this question up. So this is, so if you look onto your screen now, let's grab the next question. And I'm going to have to change the screen that I'm on so that you don't see your answers right in front of you. Okay, here we go. So here's your poll is now on your screen. So I'd like you to select just one, and what we're looking for is which of these exercises are contraindicated, so i.e. we shouldn't do them with clients that have a hip replacement. So a client that has a hip replacement, which of these exercises should we not be doing? So we've had about 20 seconds, we've got one vote already. I love it, fantastic. Really, really good. Keep these votes coming in. So just select one, and which one should they not be doing? So which is the least appropriate for them? Let's give it a couple more seconds. Okay, great. So the answer we're looking for is lying glute stretch. This one we even spoke about because they're going through that massive amount of abduction. Totally contraindicated to do a lying traditional glute stretch. Now these could be two ways, either like the footballer glute stretch, whereby your ankle goes on the leg in the other leg and you open the knee all the way out, so it's really abducted, and then you pull the leg towards the body. That's going to be a glute stretch. But anything that is a glute stretch is basically promoting massive hip flexion. So what we want to consider is not doing that with someone that's within their 6 months of a hip replacement. Nice one. Okay, really good on those levels of interaction, so fantastic. The other three on these are actually really good for them to do. I can understand why you might think treadmill, based purely on the fact that treadmill can cause impact, but it's fine for them to walk. We just got to monitor intensity, so it's not a definite contraindication. Also then we've got walking in waist deep water. We said that's a good thing. Standing quad stretch is a good thing, that's fine. We might need to consider the range of movement on that quad stretch in relation to being able to reach their feet though. So that's one thing to consider. Okay, great, well done on the poll, really good. So just now we're reaching the end of this bit in relation to joint replacement. If you just pop a little comment in if you've got any questions in particular about joint replacement, and I'll have a look at those just as we head in towards osteoporosis. So this next one is all about osteoporosis, and what I'd like you to do is just take a moment to reflect. Even though this one's come up on the screen about osteoporosis, just take a quick couple of seconds just to reflect on what we've said about joint replacement and knee replacement. If you're using it as your case study, then really think about, how does this apply for my case study? What do I need to do differently? The same goes with the first two that we looked at as well. How does that apply? What do I need to do differently for my case study, or for a client that I know, or someone that I know? What can I do that means that I'm giving them the best journey possible to help them on their way? Great. Okay, nice. So no particular questions coming in, so let's move straight on to osteoporosis. This is one you've definitely heard of. We study it at level 2 as well, so whether you've done level 2 gym or exercise to music, you would have studied osteoporosis as part of your level 2 anatomy and physiology. Now, it is classed as brittle bone disease, but basically it's the fact that calcium and other minerals get leached out of the bone and can be lost from the bone. And that means that the mineral density, the bone mineral density, is decreased. Now, as that's reduced, it means that they're much more fragile and more likely to fracture, and they're brittle and weaker. So that's really what we're looking at. The three most common sites are spine, wrist, and hips. Now, that's not only because they're more porous areas potentially, but it's because of what we put that area through. So if you think if you're going to fall over, maybe a little bit dodgy on your feet, or you suddenly trip over, all of us would put our hands straight out in front, and that's then going to cause a wrist fracture if we've got weak porous bones. Or we might be hit from the side, or we might trip over the side and land on the side of our hip. Therefore, we end up with a hip fracture. That hip fracture generally breaks across the femoral head, and that then means that they need a hip replacement. The other side is the spine fractures, and actually I had one client, she was not your classic osteoporotic type of client. She was a very tall, quite stocky lady. She was an ex-policewoman, so she always used to do weight-bearing exercise. She was always on her feet, and she had back pain for years, like 4 or 5 years, and they just kept putting it down to, oh, you stand a lot, or whatever it might be, or you do lots of lifting, you need to take it easy. And she finally kicked up a sting, and she went to a physio. And this was back in the days when physios could do manipulation, so it's a little while ago compared to now, whereby most of them aren't able to do manipulation as part of it. And she lay down on the couch, and the physio was doing work with her, and what actually was happening is she was in excruciating pain as the physio was manipulating her spine. And the physio was like, I don't know what you're talking about. Why do you think it hurts so much? Thinking that she's kind of being a bit weak about it. But basically on the couch, what was happening was that the physio was causing fractures to the spine. So the different types of fractures that happen in the spine, you can get them that go across the actual vertebra, whereby it looks like a normal kind of fracture in a bone, or you can get compression fractures, whereby if you take, it's like taking a donut and then squashing it. It literally is a case of it collapses inwards, and whereby it's so porous in the middle, it just hollows out. So these compression fractures and the other fractures are really painful because there's loads of nerves around our spine, but she was getting all these compression fractures happen, and obviously they were like, I don't understand why she's in so much pain. She went and had a scan on it, and it showed that there were 3 fresh fractures up and down her spine. She was in even more agony as a result, and the reason why they happened is through excessive flexion and extension that she was put through in that session. So it just shows that osteoporosis is not just a case of, oh, now they're a bit weaker, I've got to be careful I don't fall over. It's literally a case of it can be really bad and really painful, and we've got to be really considerate to the types of exercises that we encourage our clients to do, because we can actually cause a fracture and we don't want to be walking around with that on our hands. Okay, so there are over 250,000 fractures every year from osteoporosis. It's around a lot. There's a lot of it. About half women and 1 in 5 of men over the age of 50 will break a bone as a result of osteoporosis. So notice that is a lot higher in women than it is in men. The reason why more women get this than men is because of the result of estrogen. Estrogen keeps our bones nice and strong, and encourages the calcium to be laid down in the bones. However, when menopause occurs and we no longer have as much estrogen going on, as a result, there ends up being a lack of this density in the bones, and calcium starts being lost from the bones. It encourages osteoporosis. So postmenopausal women are basically 50% likely to have it. So we've got to be really cautious to look out for these signs and symptoms before they rely on getting a fracture to show it. There is obviously massive considerations on relation to having this. So let's just look at these images that we have on screen now. These are the differences between a healthy bone that does have gaps in it. It definitely has gaps in it. It looks a bit like a crunchy bar. It's solid, it's very supportive and strong, and there are some little holes in there, some little bubbles, but it is strong. So if you think about a crunchy bar, I could talk about chocolate all day long, by the way, guys, just to kind of throw that out there. If you have a crunchy bar out in front of you and you press your hand down on top of it and you put a little bit of weight on it, it doesn't really break. It needs quite a force in order to break it. That's the same as a healthy bone that you or I have. Then we have an osteoporotic bone, whereby that calcium has literally been leached out of the bone and the bone density goes down. This leaves big holes, big gaps, and it makes it a lot less secure, a lot less stable. So this is like an arrow. So if you have an arrow out on the desk in front of you and you put your thumb or your hand right down on that, you'll crush it. And that's the same as what's happening with an osteoporotic bone. It's much more vulnerable to break or crumble, and that then causes a lot of problems with fractures. It can cause pain in itself, and it can feel like, and it can be weakness all along that area. As a result, it can also cause a loss of height. Remember I was saying about those compression fractures in the spine? That would literally compress down the height of the spine. So that's usually accountable for why so many people lose height with older age, especially women. Then that can lead to kyphosis, whereby the compression starts to cause a deterioration in the shape of the spine. So think about that compression fracture starting to influence the shape of the spine, and they end up in this kind of forward flexed kyphotic position. And we're all aware of what kyphosis is. That's you're hunching forwards, whereby the exaggerated curve of the thoracic spine. Now, there aren't any visible signs that someone's got osteoporosis. So usually when people have a bone break, that's when they then get it assessed and they go, oh, I've got osteoporosis, or I've got osteopenia. Osteopenia is the onset of osteoporosis, so it's the thing that happens just beforehand, and it's a sign that their bone density is on the way down. But when their bone mass density is more than 2.5 points off the standard deviation of normal bone health, that's when they're classed as osteoporotic. So the actual definition is, if you imagine the actual line, a line on a graph that says this is where someone should be in terms of bone density at various ages. If they deviate from that line by 2.5 points on their bone mass density chart, then that's a sign that they're classed as having osteoporosis. So that's what we're looking at in relation to what's actually going on in our osteoporotic clients. They are more likely to have it, as we said earlier, sedentary lifestyle in particular, whereby they're not loading the joints, they're not weight bearing continually. We've heard of this before. Make sure your clients are doing regular weight bearing activity. That can be as much as just walking, but we want to make sure there's weight bearing. That their diet doesn't maybe include enough caffeine, enough calcium to make sure that they are replenishing those stocks. And also we said about the vitamins that help the uptake of calcium in the body. So vitamin D is really important for that, in the uptake of calcium and pushing that into the bones for storage rather than the leaching out. Also, things like smoking, alcohol, caffeine and carbonated drinks can encourage the leaching of calcium out of the bones. So we want to kind of consider where our sort of habits sit in relation to our bone health later on in life. The other side of this actually isn't on here, is the weight of that client, because if you think about weight bearing, if someone's very light or very underweight, they are more likely to have osteoporosis, just based purely on the fact that they are a smaller frame, they're carrying less weight on a daily basis. But there is obviously things tying into that in terms of their activity levels as well. So then the non-modifiable is age. Is it hereditary? There are some medical conditions that can lead to it. There are definitely some medications that can lead to osteoporosis, in particular things like steroids, because these steroids are going to cause a leaching effect as well. Gender, ladies are more likely to get it than men. Hormones, again, it comes down to estrogen in the body, and also the body type and the low body fat. If they have a low body fat percentage, again, they're more likely to have osteoporosis as they move forward in life. And the combination of all these risk factors means that the more risk factors you have, or that client has, the more likely it is that they have osteoporosis. So if you notice someone that is ticking a lot of these boxes, then we need to kind of keep our alarm bells there, not to wait for them to have a fracture to be classed as osteoporotic, but notice whether these things are coming up, because then we might be able to do something about that, and we might be able to actually help them with some weight bearing work. So the medical interventions that these guys will be going on are biphosphonates, and these are going to slow down the osteoclasts which collapse bone, and they help reduce fracture risk basically. So you've got osteoclasts that collapse the bone down, and your osteoblasts that build bone. So C for collapse, B for build. And as these are happening, the osteoblasts after a certain point in our age stop off, but the osteoclasts continue to break down the bone. Now, these osteoclasts can be slowed down using biphosphonates, and just the very nature of the word phosphonate, phospho means that there's calcium in them, so it's calcium carbonate. Then you've got hormone replacement therapy. This obviously relates massively with ladies post-menopause, whereby their estrogen levels are what is affecting the fact that they are going to get more fracture rates or be osteoporotic. Helps maintain their bone mass density. The same things as they might go on a selective estrogen receptor modulator, or for guys they might be put on testosterone because that helps maintain their bone mass density as well. So if a guy is particularly low on testosterone, that's what might be a good medication that they might be put on in order to maintain their bone mass density. The other things that they might be on is vitamin D supplements or calcium supplements, and usually these will go alongside like their chondroitin, etc. that they might be on for, and omega-3s generally often pop in here. And I'm seeing more and more our clients come in with us with having tablets, or they're on calcium and vitamin D supplement tablets, because it's the perfect thing to be giving them alongside a good healthy diet. We obviously don't necessarily advise on supplements, but we can talk about it in relation to the foods that they are eating and what they should be having in order to stimulate the best amount of calcium uptake possible in their diet. Side effects we need to consider, definitely gastrointestinal, diarrhea, nausea, constipation for the biphosphonates because of the increased calcium in their diet, and obviously from the tablets as well. Then we want to think about HRT. Now, we've heard about these before. They can cause cramps, bloating, dizziness, headaches. We need to think about all these side effects and how that might make our clients feel during exercise. Think about, do they have access to the toilet? Do they have access to lots of water? Are they feeling okay on that day? These are, again, all of those considerations that we need to be popping out there. In terms of lifestyle intervention, we want our clients to be making sure they're doing weight-bearing exercise. But again, I must say, if they've got osteoporosis, or it's secondary especially, and it's quite severe, then we don't want to be doing something, say, a back squat, whereby we're directly loading high affected areas, because you're directly putting that load straight in to make it worse on that joint. But weight bearing in relation to walking, even general bodyweight exercises is perfect. Remember that cycling, rowing and swimming is not weight bearing, because their weight is being held by the machine or by the water instead. Dietary changes that increase calcium intake. There are some debates about these. I've put a few down. You've got dairy and you've got vegetables. These are the two that cause a big debate. I often hear, obviously, the common one you hear is, if you need to increase calcium, increase milk and dairy. That's like the big thing that people will be aware of. This obviously has had different press levels. Some people have said that in relation to research that actually milk and dairy don't have the great calcium uptake in the bones, and that vegetables, green leafy vegetables, are better. But the problem is, gram for gram, you need to consume a lot of vegetables in order to get that amount of calcium into the bones anyway. And then there's obviously the thing about the different calorie uptake and different fat percentage of those types of foods. So there is some bigger questions over what to suggest. Generally, I would suggest that they have a good variety, a good healthy level of all of these, because they're going to help them in their quest to keep nice healthy bones regardless. And we want to be looking that they're not having excessive amounts of fat in their diet in relation to their general like nutrition and diet advice regardless. So I would always stick to the healthy eating guidelines, but being very mindful just to make sure that they are consuming what we class as calcium rich foods, which again, milk, dairy, green leafy vegetables. If you think that they aren't, and you're worried about the levels that they've got, or maybe they've got some special eating requirements, for example, if they're vegan and you're like, oh wow, they're vegan and they're osteoporotic, what can I suggest for them? I would refer them to a dietitian, and there should be one of those within reach for them via their GP, or you might know a dietitian that you can refer them to, and a dietitian is able to dial right into all of those key micronutrients to make sure that they've got enough in their diet and give them those alternatives. Other things that I would suggest from a lifestyle intervention is reduce their caffeine, alcohol and smoking. So again, we spoke about this in the cardiovascular one. If you get yourself trained in smoking cessation, you can do that with them, or you can refer them to a smoking cessation counsellor. They work both very well alongside each other. Other benefits of exercise that we need to consider is that it's going to delay their progression of osteoporosis. We want to be doing this weight bearing with them. We want to maintain their bone density. We want to reduce their coronary heart disease and get them doing functional movement. These are all givens. Okay, let's look at these guidelines that they're going to have in terms of exercise guidelines. Thinking about where these clients are in terms of what we need to do, frequency, intensity, time and type. Looking at this, it looks very, very similar. Again, we're just going to take it really steady with our exercises from a resistance point of view and gradually build up. Be very careful on flexibility training, just to take it to mild tension. And we want to prolong the holding of the stretch so that we're not doing any dynamic movements. Dynamic movements, dynamic is fine, ballistic is dangerous. So if we're going down a ballistic route with these types of clients, we've got to factor in things like balance, we've got to factor in things like the range of movement that they're going to be able to get to, and also whether that's going to cause excessive flexion, extension of the spine, etc. So let's move on and have a look at the actual considerations for when we're moving with these clients. I have to say the biggest thing is environmental safety, and I used to be like absolutely hot on this in my exercise referral gym, that it's all about that fear of falling, and if they're scared of falling, they're more likely to fall. So it's about making sure that it looks and feels just as supportive and less likely to cause a fall, rather than even just, and also checking that you've not obviously got obstacles and things around that they're able to fall. But if they want to hold on to things, that they're able to. Offer support, offer seated options whenever you can, and whether they can hold on to a wall. Maybe limit balance work, especially straight away. No sort of bizarre balance work like, oh, they need to work on their balance, let me pop on one of those two. I knew one lady that was actually reliant on 2 crutches, and then the PT gave them just to sit on a stability ball. As a result, she went to stand up, she fell straight down, she broke her leg, and she was out for the next 6 months. So it's really important to kind of think about what we're offering them so that we don't encourage a worse scenario with their conditions that they've got. Promote weight bearing, but don't and be considerate of where that risk fracture sites are, so that we can strengthen the muscles around that area, but without totally loading on that site. So we've got to be really cautious not to load directly on the site that could cause fracture in particular. Promote activities of daily life and functional exercises. Get them out walking, get them walking the dog, get them moving around, because that's going to really help them. Get them going swimming, get them cleaning, whatever they need to do to stay functional and stay active as much as they can, because that is all weight bearing. Strengthening core is a good idea, but as it says underneath here on the restrictions, we need to avoid excessive flexion and excessive extension of the spine, because if they go through those, remember I said about Jean, who was the lady that was the ex-police woman that literally had all those fractures happen on her spine from excessive flexion and extension. We want to be mindful of those. We want to consider good lifting technique so we don't make things worse or go into more fracture, and we want to take care with any kind of unsupported spinal flexion, that's what we were saying about a moment ago, or weighted rotations as well. Big risk here is that they fall over and break something. Let's dial into these restrictions for that final part now. So this is about the selection of exercises, is about how they are progressing through their conditions. You might have somebody who's straight in with osteoporosis, fairly healthy looking. There is no pain. They just have been diagnosed with having osteoporosis, and they're actually okay to go ahead and do normal type exercises, but we just want to be mindful that we don't overly flex the spine in a dangerous way that could cause any kind of fractures. The other side of that is if they have sort of a reduced functional movement, then that's the area that we want to be working on. We want to be building those up. We want to avoid high impact, so no big depth jumps, no big body attack style high impact exercises. We want to really make sure that we're working with them in a non-impact way. Consider their side effects, and also the final part is that some exercise positions might be inappropriate, and that's things like supine lying, so lying on the floor with their face up. So lying on the floor with their face up, that might be inappropriate for them to even get down there based on how far through the condition they are. When they're very far through, they might be dependent on a walking frame, they might be dependent on a wheelchair, and think about all of those restrictions that now come with that particular client. But the main restrictions to consider is high impact and excessive flexion of the spine, and not doing anything that encourages them to fall over. They're kind of our main points for the restrictions. So there's quite a lot in there about osteoporosis as well. If there's anything new in that, just pop that down in the comments box so that we can refer back to it. But I want to take you straight through to meet Georgie. Now, Georgie is a 48-year-old female. She has a BMI of 18. We're going to do some planning work with Georgie. So BMI 18, remember, is just under normal. Normal is 18.5. She has osteoarthritis in both knees and she has osteoporosis. She's on non-steroidal anti-inflammatory drugs. She takes them as she needs them, so just some ibuprofen to relieve the pain in her knees, and she's also on a hormone replacement therapy. She's a school teacher and she used to run ultra marathons, so we're assuming she's on her feet a lot. She likes activity and she's of a good BMI, if anything a little underweight. She loves walking the dog and going hiking, so there we go, she's already got lots of activity in there. She would like to be able to run again without pain for days after in her knees, so we've got her goals. Now she admits to undereating and feels scared of gaining weight like her friends have post-menopause. So she's kind of got a fear based here, whereby she's worried about eating too much in a way that will make her gain weight now she's post-menopause. So this gives us a bit of an indication in relation to her BMI. She has also broke her wrist recently when she tripped over the dog. I don't know what type of dog it is. And then she's also quite fearful that she might get another fracture. So with Georgie here, just consider all those things. We'll pop back to here in just a second so you can see it. These are the things that I'm going to ask you to just comment in the comment box about. So we're going to have a couple of minutes, maybe 5 minutes tops, just to go through what are the advice we would give Georgie. What nutrition advice would we give her? What mindset advice would we give her? Remember, she's quite fearful. And what exercise advice would be best for Georgie. So let me go back on here so you can see it. Pop some comments in the comment chat box and we will go through all of these and what comes in. What do you suggest, what do you advise is best for Georgie to do? What is best for Georgie to do? Okay, great. So you might strengthen the quads as a priority from an exercise point of view. So all of those muscles around the knee will help with her arthritis in the knee. What types of exercise would you guys use to help around the knee strength for osteoarthritis? So pop all these comments in here. Great comment coming through about the fear that Georgie has. So if she's really fearful that she's going to get another fracture, then most of our program work, both mindset and exercise and even nutrition, has to be all about building her confidence in herself so that she feels okay to go out and walk the dog still, so she doesn't start isolating herself. Definitely agree with strengthening around the quads, strengthening the hamstrings. You could go down the isolation route by doing things like knee extensions, leg curls, but functional exercises are going to be even better for her. So things like sit to stands, or you might even look at some basic bodyweight squats. Other things that are coming up in the comments box, I totally agree with these. This is her relationship with food. I think this is her biggest thing. She's already under on her BMI. Has she always been under? Lovely question. I really like that. Has she always been under on that BMI, or is this a recent thing following her menopause? What is that relationship that she has with food? Can we get a food diary? Great, I love that. We definitely need to go down the food diary route to see what's going on, don't we? And give her some good information. Is it the quality of what she's eating? Is it the quantity that she's eating? Does she have good volume and small sizes? I like that, Michelle. That's really great. Or does she lack a balanced diet? What is it that she does? Oh, I like that. She's got a sweet tooth, just like me. Fantastic. Okay, then the other questions and comments coming in and different suggestions. Start at low reps. Fantastic. Start low reps. Remember we said that she might start off doing 2 to 3 reps, just so that we don't, especially around the knee, because we don't want to work on getting that to a point of pain. So we're going to really progress this. So it might start off with just a couple of reps in the first few sessions with her, but the aim of getting her up towards endurance rep ranges, so that we're not kind of, yeah, lovely. So we're gradually building up to this 10 to 12 rep range, maybe even into endurance, but so that she's at a point that's functional for her to do. Love the questionings of why. So you guys are really starting to dial into why things are happening, and really popping into this chat box now why your client might have tripped over the dog in the first place. Why she tripped over. Was it dark? In which case we can avoid walking the dog in the dark, potentially. Or get one of those nice high-vis little jackets. Look fantastic. Or maybe she tripped over the dog because it was running around her and she couldn't control it. Maybe it was from a particular incident that happened. What happened and how can we avoid that to help boost her confidence? I love that as a question. That's really great. Fantastic. Keep those comments coming in and we'll wrap it up in a couple of minutes. Sit to stand exercises and step work is a really good type of exercise that we can get her to do because it's functional. It will stop her from having a fall in the future. Anything that involves the work around the hips and the glutes, so all that kind of abduction work whereby you're taking the legs out to the side, really working around the glutes, is going to help her feel more stable, definitely. Hopefully explain why it happened to give confidence that it won't happen again. Yeah, absolutely. So if you explain what's happened and you give her the best information you can about what's going on in her body, she'll feel more confident that it's not going to happen again. I totally agree with that. So you guys have got some really great comments in there about what advice you would give your client or Georgie based on her nutrition, her mindset, and also her exercise. So massive high five for all the info that you popped in there. If you've got any extra bits that you really have, or this has thrown up any questions, then pop them in as well. So let's start getting some questions underway. So I think that's most of our questions all done and dusted. So massive high five for playing full out today. I hope you've learnt a lot in relation to musculoskeletal. I've certainly seen a good couple of comments come through in relation to learning particular areas of it. So a massive high five for everything that you guys have digested. I'm going to close down the webinar now. If you've got any extra questions, please do send them across to info@parallel-coaching.com.